delighted to welcome Richard Grieve from the London School of Hygiene and Tropical Medicine. So Richard is somebody, I think your title is Professor of Health Economics Methodology, no?
That's
and
it,
so
yeah.
You're able to answer all sorts of, all the questions about how to do any sorts of evaluations. Richard is involved in some very high-profile evaluations at the moment, and the title of the seminar today is Advances in Health Economic Evaluations Methods in the Absence of Random Allocation, which is something that is extremely useful for many of us who are working also on evaluations. I think you're hoping to leave some time for questions at the end, but you're also happy to be interrupted for clarification questions as you go along?
Absolutely.
Fantastic. Well, you know.
Yeah.
Thank you very much.
So much. Thanks for the invitation. I think it's at least 10 years since I last spoke at LSE. In the meantime, you've got loads of new buildings, newfangled stuff. One thing that hasn't changed is my ability to get lost in the building, which Google Maps just about saved me from. So it's good to be back. Thanks for the broad title that Maria encouraged. I guess I've chosen to focus it in a couple of ways around a couple of areas where we've, I think, made progress, and an active piece of work we've got on at the moment that I'd like to get some discussion going around. So this isn't by no means all my stuff. The people there have worked hard with me on aspects of the problem. The funding is from NIHR, and I'll make slides available from this afterwards on that website. So please get in touch with me if it raises concerns, interests of yours. So I thought the first bit I would just give some context. Why non-randomized studies are of interest, and I would argue of growing interest to decision makers. I'll talk about a development a few years back which I think has got more legs and more currency than we perhaps realise, and then I'll talk about something we're active on at the moment and raise some points for discussion. So in terms of the context, as of yesterday we had a BMJ editorial about the Cancer Drugs Fund, which is moving to heavy use of non-randomized data. If I've got this right, basically NICE, having taken over the work of evaluation of all new cancer drugs, will have three choices. It can either say yes to an intervention, it can say no to an intervention, or it can say maybe. And if it says maybe, then there's a requirement to collect the dreaded term real-world evidence as part of that therapy's use in the routine NHS, which opens the door for companies to not collect phase 3 randomized data and rely on this route using non-randomized study in order to get a drug reimbursed on the NHS, which is potentially a game changer. And in the editorial we raised some big concerns about the way that process has been designed at the moment. Put candidly, I know this has been recorded, I think it's the worst form of observational study you can design, the way it's being couched at the moment. And I hope that some of what we talk about today will be about how we can improve the design and analysis of observational studies. It's not the only show in town. You know, there's a lot of pressure about accelerating access to medications which are argued to be effective, and there's various sort of pathways to integrate reimbursement with regulation, and this might imply, again, much heavier use of phase 2 early stage trials and non-randomized comparisons. I suppose more widely as well on the data side, we've seen progress in some regards in the linkage between primary, secondary, social care data, disease registries, and this again offers huge opportunities for a broad raft of evaluations, not just health technology assessments but health policy evaluations as well. So I think it's an exciting time to be working on observational data, but we also have to be wary of this non-random assignment that we're always dealing with. So here's some examples. People have used regression methods, propensity score methods, IV methods, where you might only have summary data for one of the comparisons. You might use matching adjusted indirect comparisons. The main concern I have, though, is where decisions are being made, as with the first NICE CDF decision, just on a naive comparison of 12 individuals in a control arm versus people in the phase 2 trial who got the treatment, and drawing causal conclusions and policy conclusions from that. So, you know, there's a cacophony of evils here, and I think it's our duty as researchers to spell out the assumptions and come up with more appropriate methods. So a key issue is how you design the study in the first place. So we might have a before and after study where we have a policy introduced, we measure outcomes before that introduction of that policy and then afterwards. And as with the historical cohort study design, the concern is that things other than the policy will have changed over that time of evaluation. We might have a concurrent cohort study where we have a control regimen measured at the same time in terms of baseline and outcomes as the treated, and that offers us some hope in terms of being able to make unbiased estimates. But of course, if there's unobserved differences between the two sets of patients, then we've got a problem. Longitudinal studies can potentially help us here, where we have measured potential confounders over time. That can allow us to adjust for some aspects of unobserved confounding. But we're always dealing with a setting where we have non-random treatment allocation, and so I think the central concern is always going to be selection bias from confounding. And what I'm going to talk about now is design as well as analysis strategies to try and minimize that problem. So just to give you something else sort of newsworthy to go on, only last month the hormone replacement therapy controversy came back. The controversy arose because back sort of 10, 15 years ago, observational studies had suggested that hormone replacement therapy was universally effective, but in fact, subsequent trials, the most recent of which reported in August, have found that it might only be effective for particular subgroups of patients with particular types of regimen. And so the unilateral conclusion that people like NICE were following, that it worked for everyone, whatever form it took, was thought to be misguided. And the concern really arises because of our old friend unobserved confounding, in that people who were on these regimens were somewhat different, not just according to observed factors such as age, but according to unobserved factors such as lifestyle factors and or socioeconomic characteristics. The time at which they took the therapy might have been somewhat different to those who didn't have the therapy. They might have been in a different place in their sort of disease pathway. And the net effect was that there was imbalance not just on observables, but also on unobservables. And that might well have led to different conclusions to the trials. Of course, the trial populations could have been different to the observational studies, and that could have been what drove those different results. That's an issue with that sort of design of comparing benchmarking observational data with trials. But unobserved confounding is undeniably a problem. So what can we do? Well, traditionally we've sort of cut the world into two halves really and said, well, we can either try and measure everything we can and adjust using regression or say matching, or we recognize that that's impossible and use a method such as instrumental variable estimation that purports to allow for both observed and unobserved confounding. And what I want to get to in the second part of this is to sort of blur the edges of this dichotomy really and look at combining methods such as matching with instrumental variable estimation. It'd be interesting to hear your views on that sort of approach. The last bit of context is, of course, around methods development versus what's actually being done in the field. And so we did a review of economic evaluation, and we found that of these 80 studies, almost all of them used methods like regression and matching. I think only 2 studies used IV, and those studies that did use regression and matching failed often to even mention no unobserved confounding as being a problem, and those that did use the IV didn't really justify the requisite identification assumptions. Why? Well, I think the recent NICE DSU document talks to the gap in training and dissemination. So there's often people working on methodology, people doing applications, and never the twain shall meet is perhaps a problem. So I think that's something general in health economics that we need to be aware of. In terms of improving the situation, I'd argue and had some traction in the latest NICE DSU document, which is coming out soon, that it's not just the widget, it's around the design. And so you know, if we're just stuck with a before and after design or concurrent cohort study without any longitudinal data in sight, then there's limits to whatever we can do with each of these estimation techniques. Our identification strategy faces severe problems. Arguably, though, that excuse is no longer there often, and this is an example of a paper we got into the BMJ that had excellent observational data, I'd argue. We had HES data linked to PROMs, linked to National Joint Registry data, which enabled us to carefully define the interventions and adopt, I think, quite careful adjustment methods for the inevitable risk of confounding. And so I would like to see people thinking more about design than is routinely done. In terms of the first recent development that I'd like to discuss with you, it's around matching. So why might we go further than, say, traditional OLS regression? Matching also assumes no unobserved confounding. But the difference with regression is that we're not reliant on the correct functional form of the regression model. And a particular concern is we might not know the relationship between, say, baseline quality of life measured before a hip prosthesis is done and eventual quality of life after they've had the replacement in place. And so regression is very susceptible to the concern that that relationship is misspecified. What if a treatment effect is specified as additive when in fact it's multiplicative? And this can lead to bias and inconsistency, and a particular problem when you have very big differences at baseline. So the paper by Ho et al. Was a political science paper, but it showed really how if you got these functional relationships wrong, you could lend itself to very biased estimates of treatment effect. A sort of more obvious problem, and perhaps we've all been there, is that when you're estimating a regression model, your treatment effect estimate is always in sight. So the temptation's there to say, well, I don't quite believe that model. The answer I get isn't quite in line with my intuition. I'm going to try this model. I'm going to try this model. I'm going to try this model. Oh, that one seems to give me what I'd expect. That's the one I'm going to run with as my base case analysis. And so a big selling point of matching is that it's done in absence of any outcome data. Or perhaps put more subtly, it's done in absence of estimation of treatment effects. It's done arguably as part of the study design. And that's certainly what we were doing in that hip prosthesis example. We were matching on baseline EQ5D and many other baseline variables. And then only once we got balance would we proceed to doing any outcome analysis. And it can be combined with regression, as we'll go on to see. So once you've got the balance as per a randomized study, then and only then could you apply all of your usual regression models. So it's a pre-processing device to try and ensure that you have comparable groups at the offset and makes you much less prone to model misspecification. So how might them? So the aim of the matching is to ensure you have balanced groups as per randomization. And the subtlety that we go on to look at is that it's not just the means, but also the variances, the interactions and so on that should be balanced as per a trial. And the principle is that you want to try and find the most similar individuals you can to the treatment arm in the control arm and in effect impute their missing outcomes, the outcomes that they would have got had they received that treatment. And then whatever treatment effect you estimate is attributable to that treatment rather than to confounding differences between them, between the arms. Of course, we're only looking at observed characteristics, and so the key assumption remains of no unobserved confounders, and we also assume that there is overlap between the groups. The second assumption is testable, and we can deal with it in the design at the outset. The first assumption is not testable, but progress has been made, and I'm not going to talk about it today, in sensitivity analyses, which asks the question, how big would the unobserved confounder have to be in order to change the study's conclusion? And more thoughtful ways have been developed for asking and answering that question. Can never be formally tested, though. So in terms of our intuition then, oftentimes we're talking about a relatively small treatment group and a relatively large control group. And so we're asking the question, how do we find people within that control group who are similar on key prognostic baseline characteristics to those people in the treatment arm. And so we want a matching method that gets us the best balance in those observed characteristics between the treated and control arms. Now, people say, well, matching is very wasteful, it throws data away, throws information away. I think my slight pushback on this would be, well, let's be very clear about what it is we want to try and estimate here. In the example I'm giving in the picture, we're interested in the treatment effect for these guys. So another way of rationalizing this is saying, well, this new treatment is coming in. We want to see if those people who are getting the new treatment didn't get it, what their relative outcome would be. And it's for them, this substratum who's of prime interest to perhaps a policymaker, that we want to estimate a treatment effect for. So I'm not interested in estimating a treatment effect for a load of people out there in the control arm who aren't in the frame for this treatment. I'm defining my population of interest with respect to people who are in that treatment group. Now, you could argue that sometimes that's not helpful and you want to estimate a treatment effect for the controls. Well, it's a harder matching problem, but you could do it that way around, particularly with replacement, matching with replacement. We'll talk on the merits of that perhaps later, with or without replacement. But my general point here is you have to define what the estimand is, and then given that, if it's ATT, you're not wasting people in the control arm by only finding people who match to the treated. You're defining your population of interest as per the treatment group. I think the other sort of general thought I have is that provided one is upfront about these things, and ideally you would be discussing this with a policymaker and saying, look, which is the population you're interested in up front, and then picking how you do the design and analysis according to that. I think that that's very helpful. In the second strand of work I'm talking about, that's more difficult, but I think it's still potentially important.
So if you just got cross-section data, I'm just thinking about
Yep.
data generation.
Yeah.
It's just cross-sectional so far.
Yeah, I'll get onto a bit of longitudinal stuff. Yeah, I mean, the same principle. So, yeah, I mean, just to that. So if I've got, you know, decent longitudinal data, then my matching method could match on my outcome in period y-1, y-2, y-3, y-4. So all of what I would call the exits are in that longitudinal data. Yeah, yeah. So one approach which has been well-oiled in the sort of applied methods literature is to use propensity score methods, where you are modelling the probability of the treatment given observed covariates. Here this might reflect that the choice of whether I get hip replacement A or B might be dependent on the patient's choice, the clinician's choice. And Rosenbaum and Rubin suggested that matching on the p-score can give an unbiased estimate of the average treatment effect for the treated under certain conditions. Those conditions are fairly restrictive and often glossed over in applied work, but it relies on the propensity score being correctly specified, but it's generally unknown and has to be estimated. So if you misspecify the propensity score, then the conditions for unbiased estimation no longer exist. Now, that sounds pessimistic and bad, but unlike regression, there is a standard set of tests for assessing whether the model is correctly specified. And those are according to whether you've achieved balance once you've matched on this propensity score. So if the propensity score is misspecified, you're going to get bad balance. Your treatment and control arms are going to be different on your observed prognostic characteristic. So you have higher age in your treatment, mean age in your treatment versus control arm, for example. So it's very important as part of the development of a propensity score model to assess the balance, match, modify accordingly. And achieving balance on many terms is clearly difficult. So it's an iterative process. So you come up, you talk to your clinical friends, you estimate propensity score model, you match using that estimated propensity score. You ask the question, are any of the key prognostic variables imbalanced in those matched data? If the answer's yes, then you've got a problem with your model. You go back, you re-estimate it, you check balance again on the matched samples, and you keep on going, you keep on going, you keep on going until one of two things happen. You get balance on everything, or you chuck the computer out the window and say, this is just impossible. And I would argue that we have a way of stopping that second scenario. So in terms of balance then, here's an example of a study I was involved with. We were contrasting pulmonary artery catheters for patients in the ICU versus alternative monitoring devices, and a key prognostic variable was the patient's baseline probability of death. Before we did any matching, the people in the PAC arm, the treatment arm if you like, had much higher baseline probability of death. So the concern is they're sticking these devices into the sickest patients, and that makes the causal estimation of causal effects very difficult. But once we've done the propensity score matching, we see these plots showing a much smaller difference in the baseline probability of death between the PAC arm, that's on the y-axis, and the no PAC arm on the x-axis. And we see that we have quite good balance at the mean. So you have a 50% baseline probability of death in both arms at that point in the distribution. But what we still see using these neat plots is that balancing the mean might be insufficient, and that we see this gap at the lower end of the distribution. So amongst the people with relatively low baseline probabilities of death, there were somewhat higher probabilities of death in the treated versus control arm. So the propensity score, as perhaps we might expect, had done well in terms of the means, but it hadn't done well at balancing the distribution of this key prognostic variable. And we'll come on to the havoc that can wreak in a second. So a motivation for this more general matching algorithm than just using propensity score matching is that with the p-score, you might never get good enough balance. So people have tried to use rules of thumb, like according to the means, you want a standardized difference of less than 10, but it might not be good enough. And so you want to try and maximize the balance between the treated and control arms, and that's what genetic matching does. So rather than continually redoing this balancing algorithm manually, which is a pain and takes ages and you might never get there, you set the algorithm the task of, given the data, how can you find me the matched sample that best balances all of the key baseline prognostic variables. And so you set that optimization task to the algorithm. And it can use the propensity score. That can be particularly helpful in terms of finding balance on the means. But you also say, please find me a balance on the distribution of that baseline probability of death variable, for example, as well. And so it's given that sort of algorithmic task to find the best balance within the data. So there's sort of theory in some of those papers. It's a generalization of Mallome's distance metric, where you're basically asking an algorithm to minimize a multivariate distance matrix. So here you've got vectors of covariates for two different observations, and you're asking the question, what weight for each of those covariates is required in order to maximize balance. And so the algorithms search amongst the data to pick those weights W, which maximize the overall covariate balance. And it then gives you the matched data set which finds the best balance that's available from that data. Returning to the illustration, we have this problem. We have this need to evaluate pulmonary artery catheterization from this observational data set, where a propensity score model had found that this device was associated with higher mortality versus no device or an alternative device. It had a big impact on health policy. This Connor study was published in JAMA. Clinicians stopped using this device. The concern we had coming into this re-evaluation of it was that the propensity score had not achieved adequate balance. We compare it to an RCT benchmark, and we use data from ICNARC, which had good information on baseline covariates and so on for 1052 PACs and 32,000 control pool. And we find, this is the chart you've seen before, where you have the propensity score still leaving residual imbalances. With this matching algorithm, set the task of maximizing balance on this and I think 50 other baseline variables, we were able to achieve even distribution of each of these variables between the treatment and control arms. What does it matter? Does any of this matter? Well, in terms of the incremental net benefit, you can say, well, perhaps not, because it's negative still. So it's still saying the device causes slightly more harm than good, but certainly the size of that decrement comes down quite a lot, and towards the size that was seen in the RCT that was done subsequently. So the RCT found no significant differences between PAC and no PAC arms, and the GEM-match, albeit with wide confidence intervals, also found no significant differences between the arms, whereas the original P-score matching had been very apparently clear, spuriously clear, we argue, in saying that this insertion of this device caused harm. So I think the general point, whether you do or don't like this widget, is that balance is key. When you're using a method that's relying on the selection on observables assumption, at least make sure that those observables are well balanced between the arms under consideration. There is a price of computational time. I would argue it's worth paying, and particularly so when you're dealing with quite awkward data, as we often are in health economic evaluation, where you have non-linearities aplenty between the baseline measures and the outcome measures. You have non-normally distributed covariates where just balancing the means might be insufficient. And it's not necessarily instead of matching, it can be used, instead of regression. I think it's a false fight, really, and that the two are complementary to one another. An interesting thing, well, I was interested in it, but was that there's been a lot of talk about double robust methods in the epidemiological literature, and we were excited to try them. We found no advantages versus what I would argue is a more simple, transparent approach, which was to combine matching with regression. An overarching point is, yes, here we're talking about cross-sectional data, and throughout we're assuming no unobserved confounding. So on the longitudinal data side, and apologies to those who wanted us to major on this, I'm only going to deal with it in one slide. We've, I think, made some progress. There's been a lack of work, I think, in cost-effectiveness analysis, which has used sort of longitudinal data from panel surveys, from sources such as HES and so on. We've seen some recent movement into that territory, such as the paper by Rachel Meacock and Matt Sutton on Advancing Quality Initiative that was published in Health Economics. They did use traditional difference in difference estimation, and the identification assumption behind that is that the two groups under consideration have parallel trends in outcome over time in absence of that intervention, which is a strong assumption. So we've been working with methods that make alternative assumptions. The synthetic control approach is one of those. It purports to allow for aspects of unobserved confounding that are left on the table by difference in difference estimation by finding those control units, the weighted combination of those control units that have similar projections of outcome over time to the treated units. And by so doing, it purports to allow for that aspect of time-varying unobserved confounding, which is not considered by traditional difference in difference estimation. We got different results to Sutton et al. When we applied it to evaluation of advancing quality, which is this P for Performance initiative. In a case study, you never quite know why you're getting different results. And so we've done some simulation work, which basically points to the differences in the identification assumption. So difference in difference is making an alternative identification assumption to either synthetic controls or lag-dependent variable approaches, which are making a sort of more of a conditional independence assumption, conditional on the trajectory of the pre-treatment outcomes. There is no further confounding. So in a way, you're never going to prove or disprove which of the identification assumptions is right from a given data set. I think the recommendations coming out of the work were that you should always consider an alternative to difference in difference estimation, we actually came down in favour of the lag-dependent variable rather than synthetic controls as the alternative because it was slightly more efficient, but that's a fairly fine point. The other general point to come out of this simulation study was about a design lesson, which is that all of these methods did badly when we had 3 or less pre-treatment outcome periods. And so, you know, that raises a concern for quite a lot of the traditional policy evaluation literature, which has just used 1 or 2 pre-treatment periods. Okay, I'm going to pitch on some stuff about IV, but I don't want to preclude any burning questions I might have had in the first part. Yep.
I have a question about the genetic matching. I found it very interesting what you said. You said that they basically relied on the same identifying assumptions as propensity score
Correct,
matching of
yep.
uncertain confounding, but I wanted to ask whether, in the detail of that, it actually involves a more stringent identification assumption.
No, the identification assumption's the same. So just to give an intuitive example, in a hormone replacement therapy, it would not have saved the day in that socioeconomics was not measured and has been argued to be highly causal of both the treatment assignment and the outcome. And so both propensity score and genetic matching would assume that socioeconomics didn't matter, basically.
Yeah.
So there's no difference between the two. They're equal on the non-observed
So
confounding
the fact that
assumption.
you're seeking to match on the, you know, ultimately achieve balance on the whole distribution, not just on the means,
Yep.
doesn't in turn require a more stringent identification.
No. No, if anything, it could be argued less because my hunch with propensity score matching is that people only present balance on the subsample of coverts that they've been able to achieve anything like decent balance on. Whereas with genetic matching, you're able to, well, you should be able to present balance on a much wider range of X's. And that implies a less stringent non-observed confounding assumption at the price of computational time. So that's where the price is. It's not around a stronger assumption about non-observed confounding, it's at the price of computational time.
Just 2 things. Could you say a bit more about synthetic control?
Yeah.
There's a bunch of things you could say.
Yes.
And then secondly, in your simulation, have you tried, as you said, with not mutually exclusive these matching and
No.
correction methods?
Yeah.
So to achieve match balance through matching, I recognize it's on covariates rather than the outcomes. Could you relate that to the parallel trends assumption if you had data? So
Yeah.
do matching to ensure that we're getting parallel plot.
Yeah, I mean, that's more or less what synthetic control, and we did matching in this simulation study as well. So, I mean, with weighting, you're obviously not giving 0, 1. So I could be, so if my treatment is in London, I could give 30% weight to my control units for Manchester, 20% to Liverpool, and so on. Whereas with matching, it's a sort of a 0, 1 decision in some ways. But the general point that you're trying to balance the pre-treatment trajectory of mortality or whatever is general to both the matching and synthetic control approach. And so that stands for both of them. In terms of the parallel trends identification assumption, the difficulty is that you can look at what the trend is in the pre-treatment period. By definition, you do not know what the trend would be in the post-treatment period of the treated versus control units in absence of the intervention. You just do not know whether that trend continues parallel beyond the point of treatment in action. And so that's why it's an untestable assumption. Now, of course, in the simulation study, we know that. And it's, I mean, yeah, this is going to seem very obvious, but when we violate the parallel trends assumption, difference in difference does badly, synthetic controls and lag-dependent variables and matching do well, and the converse is the case as well. And the difficult thing is you never know when that identification assumption holds and when it doesn't.
You just simulation, you could look at the trade-off between the matching and the outcome, sorry, the parallel trend.
Yeah. But I mean, matching's making a very different identification assumption. It's making a selection on all pre-treatment data assumption, whether that's outcomes or covariates or whatever. Whereas difference in difference is making a different identification assumption, that the counterfactual outcomes continue parallel beyond the point of treatment. and you can't test either of those assumptions. All you can do in a simulation is say, when I made this is how bad the bias is in that, and when I make this other assumption, this is how bad the bias is in that. And so, you know, it was a useful exercise because, I mean, the other thing that no one in the literature had really written down what the identification assumption behind synthetic controls was. And so I think making this plain for people was of some use of itself. But yeah. And this thing about the number of pre-treatment periods as well was something I'd worried about for a while but hadn't seen people demonstrate. You know, so even with 3, you're in a bit of trouble if you have the level of variation in that pre-treatment outcome that we saw in the HES data that we were analysing.
You should never do long difference.
Or if you do, you should, It is recorded, this, isn't it? Okay. Okay, so, I mean, up to now we've assumed non-observed confounding, which I'm using interchangeably with selection on observables, but of course we might have opportunity, particularly with these big new data sources that we're accessing, to have an instrumental variable. And in the literature, distance to specialist centre, or the prescribing choice of the clinician about the preceding patient, or some other measure of supply-side constraint are all advocated in some paper or other as being potential instruments for the treatment you're really interested in. And Basu and others have done decent work on how these can be extended to estimate subgroup effects and so on. But an overarching concern is often in these natural experiments the instrument is fairly weak. And by that I mean it only has moderate association with the treatment that you're genuinely interested in. And in the general literature they've said where this is the case, you can get bias, however big the sample is, because even if it's if the level of the instrument is slightly dependent on the unobservable, you're going to end up with imbalance on the U's and potential bias coming in. So of course we should all do randomization, have a strong IV, and stop worrying. But that's not the game that we're in. So we're in the game of trying to strengthen the instruments that we have in this paper. So we've got this unobserved variable that's a common cause of both the treatment assignment and the outcome. This could be the patient's underlying health. It could be their expected gain from the new treatment, contextual factors, level of risk aversion, and so on. And we've got this IV, and we're using this to break this unobserved confounding. And by definition, this variable has to be strongly predictive of the treatment. It has to, the levels of this variable have to assign patients as if at random, so that they have an even distribution of observed and unobserved characteristics between the two groups defined by the instrument. It has to meet the exclusion restriction in that it only has an effect on the outcome via the treatment receipt. It doesn't have a direct effect. And there's a couple of other assumptions that are always trotted out in the literature that in some ways are a little bit more innocuous. In the interest of time, I'll skip to the essence. So the problem is that if the instrument's weak, you get bias. And what this paper, this work that we're following says is let's strengthen the instrument. And let's do it with what they term a study design approach. And the essence of the argument is that within the observational study, there is a trial, if only you could find it. So there is a trial in there somewhere. There is a stratum of patients who are getting treatment A versus B at random. And can we help find these patients with use of a matching phase to prepare the data for analysis? And so we use this matching to find people who are, as before, everything we've said before about the need for similarity on observed covariates still holds, but we also want the patients to be far apart on the IV so that this IV is strengthened. And if we do that, the argument is that it provides consistent estimates because you've balanced not just the observables but the unobservables between the treatment arms. So the task for the matching algorithm is to find within matched pairs individuals who are very different to one another on the IV, as well as similar to one another on the observed covariates. And if you think about it, that's what you have in a trial. So in a trial, if one half of the room got assigned to treatment, the other half to control, and this was done at random, two things would be true in a well-designed trial. You'd be similar between the groups on observed characteristics, but you'd be very dissimilar on the treatment received, in that arm A would get a very different regimen to arm B. And that's what's the logic behind this near-far matching. Far on the IV implies very different probabilities of getting the treatment. So let me give you an example as to how this might be done. And I was talking to Maria on the way here about guidelines work, and it's often a very difficult area with sparse data and so on. But here's an example of where there is a guideline out there, and there's probably not much evidence to support it, and we're going to use an instrumental variable approach to see whether this guideline is reasonable or not. So under the guideline, patients who are admitted to hospital, deteriorating health, should be shifted into ICU after 4 hours from their assessment for ICU admission. So these people are all very sick, they're deteriorating, and they're assessed for ICU admission. And some of them get admitted to ICU within 4 hours, and others don't. They either don't get admitted at all, or they get admitted with delay. And we want to ask the question, what effect does this prompt admission have on mortality? Does it reduce mortality or not? Now, the studies that have attacked this question before have run into real difficulty. The first problem is a design one. So I'm going to bang the drum about design one more time. They didn't follow people up who didn't get into the ICU. And so that's a real problem in terms of defining the counterfactual. You need to follow the people up who languished on general medical and died if their counterpart went onto the ICU and survived. You know, that's an important design feature. And the second problem was that they assumed selection on observables, and this is a very challenging area for methods like regression to work because there's going to be unobserved prognostic differences between the modalities. So there's this study called Spotlight. PhD student Steve Harris, clinician at UCL, did a great job on designing this study, I think, because the crucial thing he did was he didn't limit his sample of interest to people who were admitted to the ICU. He followed up 13,000 odd people who were assessed for ICU admission, including those who didn't later get ICU admission. So 2,500 were admitted within this window, 10,500 weren't. Naive and regression analysis found that it killed people getting to ICU quickly, which seems wrong. Prompt ICU admission versus not was our question, and we used as an instrument the bed availability in the ICU at the time of assessment. So the thought process here is that if the ICU is full, when Ali presents, he's less likely to get in there. I might have exactly the same prognosis as him, but I might be lucky in that when I arrive, there's 3 beds available in the ICU. So we've got identical prognosis, but I get in and he doesn't. And so contrasting our outcomes, pretending for a moment we were the same on everything else, might be of interest. We've almost got, arguably, the argument there is we have randomization between us as to who got it and who didn't, according to the level of this instrument, this bed availability on ICU. And we have some natural variation here. So the median was that 4 beds were available in the ICU, but about 10% of patients when they were assessed, there wasn't a bed available, and there's tons of beds available when they come in, and it's argued to be exogenous in that, you know, it depends on what else is happening around the hospital, around the area at the time. There's some stochastic variation in the beds available over time, as well as some more systematic variation by centre and so on. So, yeah, we can talk about the story some more, but basically the idea is it breaks this, this problem. The instrument is not mega strong, so its association with transfer within 4 hours gives us an S-stat of 10, which is absolutely on the borderline of rule of thumb for IV. So if it was 3, then we'd be golden, we'd be as per a trial. If it was if it was 30, we'd be golden, it would be as per a trial. If it was 3, we'd be in trouble. 10, it's not ideal. But yeah, we're going to work with that. So So what we're going to do is we're going to first look at whether there's observed differences according to the level of the instrument. And what we see is that something like age, it seems to be reasonably well balanced between the people who were discouraged from going to the ICU and people who were encouraged to go to the ICU. There's reasonable balance, but for some variables such as admission during the winter, there's quite big imbalances, which suggest not only is the instrument not strong, but it's not perfect in terms of giving us an at-random allocation of the two groups. And so we need to do both these things. We need to strengthen the instrument, and we need to make sure that we're balancing the two arms that we're interested in. So in brief, our task is to find matched pairs that are near on the covariates that we've observed, far on the IV. Our ideal match would have people identical on observed characteristics and very different on the occupancy level that they face, or the bed availability that they face. So within a matched pair, people would be the same on age, winter, and all those observed characteristics, but one unit would be very strongly encouraged to take the treatment, prompt ICU care, and the other would be very much discouraged to take it, i.e. there were no beds. And so that's the way that this matching algorithm is set up. We specify a threshold, effectively a reverse caliper, a distance that we want to exceed on the instrumental variable. So we don't want people being matched who neither of them it's possible for them to get into that ICU within 4 hours. We want some difference on that. And we want to recognise that we want to balance the observed characteristics. Now here, there's no free lunch, because in a way there's a trade-off being made. The more I push people apart on the instrument, the more prone I am to be pushing them apart on other things as well. And so inevitably the algorithm has to discard units that fail to achieve the criteria of both improving balance and strengthening the instrument. And that's an inevitability of this method. So, you know, there is a limitation there. You're going to end up making causal inference for a subset of the people that you started out with. And so that was one point I was making at the beginning. We have to be very clear to the policymaker that only for this subsample are we attempting to make causal inference, and we'll come on to them. So C on that is a scaling factor. So we're doing a multivariate distance matrix here, and so we're basically calculating our distance apart on many factors, and this factor is referring to the instrument, and we're putting a penalty on people who are too close on that instrument. And the reason we're putting a C, a scaling factor, is to put it on the same scale as all of the covariate information that's inside there as well, all of the X's. The crucial parameter to really, I think, is this one. It's lambda. I didn't use the traditional lambda because we've got other purposes for that in cost effectiveness analysis. It's capital lambda, the size of the caliper, the size of the tolerance. So if you say, I'm really concerned about having a mega strong IV as per a trial, then you bump up the size of lambda. And if you say, well, no, actually, I don't mind, as long as it just squeezes past a weak instrument test, I'm happy, then you have a lower value for that. And that's a somewhat arbitrary choice. Now, what we've done here is we've benchmarked it against what people have used before in the literature, but not today, but in the paper, we show a sensitivity analysis about what impact changing the level of that caliper has on the results. But that's something that's under our control and, you know, should be defined at the design stage. Okay, so, yeah, we need to get to the point where we can have some discussion. Okay, so the last thing to say, and this is maybe a tweak, in that the way that this study is designed, we have 13,000 patients across 48 hospitals, and there's a worry that when we do the matching, we end up with very big imbalances across the hospitals. So akin to a sort of a fixed effects analysis, we extend the existing algorithm to try and ensure balance between the hospitals. So effectively, you're doing an IV within each of the 48 hospitals. That's one way to look at it. So at the end of it, you're balancing the number of patients per hospital for the few versus more beds available groups. And that, again, narrows the population you can estimate causal effects for. So I'm going to skip through this quite quickly. Please forgive that. There's, as I say, a paper that if people are interested, I'm happy to send you. It's in draft form at the moment. But basically, what we're going to do here is we're going to do the matching twice. The first match doesn't respect the hospital structure of the data. The second match does. We're going to report balance, and we're going to report treatment effects as the effect of encouragement to prompt ICU care versus not on 7 and 28-day mortality. So what do we find? We find that basically both of these balance tables show the strong instrumental variable when we've done the matching. The first balance table doesn't respect hospital, and you get a lot of variation across the hospital still in the distribution between the two groups. The second algorithm respects that, and we've reduced the distance, the imbalance at hospital level. And we also have you want imbalance in the ICU bed availability. That's your instrument. Standardized difference of that big is showing a strong instrument, but you want everything else to be nicely balanced, and the standardized differences being less than 0.1 show that we've managed to achieve that. In terms of the outcomes, what do we find? We find that whether we look at 7 or 28-day mortality, whether we look at the simple algorithm for strengthening the instrument or the more complicated one, we find a reduction in mortality according to the point estimate following prompt versus not prompt, delayed or no ICU admission, up to 25% reduction in 7-day mortality with the strong IV and the refined balance matrix. Note though those confidence intervals are wide and the p-values exceed traditional cutoffs. So we have a point estimate that a priori we might expect. We have a lot of uncertainty about that point estimate. So in summary, I think this method has some appeal in that it thinks about the design of the study. And by design, I mean how we sort of structure the study, how we define our groups, and how we strengthen our IVs so that it can give us something akin to an at-random allocation. And we do that by combining matching with IV, which we haven't seen often much before in the literature. So we're trying to achieve two things: strengthening the IV and maximising the balance so as to try and reduce the inevitable bias that comes from these studies. The price is that here we get a local treatment effect for a restricted sample. And that's what we get in a trial. So perhaps a controversial question for discussion: is that a bad thing? Is that something a policymaker can live with if we tell them this is the sample that we're giving you a treatment effect for? So we're giving it you for people aged 65 on average who have this physiology admission with a 27% chance of being admitted in the winter, blah, 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 rather than the initial target population that we started with. Can a policymaker live with that? Should they live with that? It doesn't achieve statistical significance. IV methods are traditionally provide noisy estimates, and that's something that comes with the territory. And once we're throwing away information, that problem isn't going to get any better. It might well get worse. We see larger gains from more severe subgroups. I haven't presented that now, and that will be in the eventual paper. And I think this design approach is useful more generally for evaluations that rely on natural experiments. Okay, I'm going to finish up there and allow time for a couple of questions, but just to say that, yeah, this is an ongoing area of work, and it'd be nice to get your feedback.
Thank you very much. We've got literally a couple of minutes for some very brief questions.
A question with your fundamental design, in the sense that IV has to its a local fact.
Yep.
Possibly the option you might want to have. The thing is, with matching the screen, making the estimate do more of
Yep.
discarding some observational data. My question is it possible to interpret the estimate as upper
You are keeping the observations who are most likely to be affected by the instrument. That is true. That is true in general for IV methods. And you're within that limiting it to the subsample who are balanced between the treatment and control arm. So it's that subgroup of the subgroup who you can be making inference for. Now, if you want to make inference for a wider population, then you're going to have to make assumptions. And my inclination here is to say, well, those assumptions might not be valid. You know, they're big assumptions that you're making if you step out from that stratum who we can make inference for. So in that broader group, the instrument doesn't appear to be valid. You're not achieving balance, and it doesn't necessarily have a contrast treatment versus control that's particularly strong. So I'm not sure from the policymaker thinking of that broader group is necessarily helpful.
Last question.
Thank you. Just following up on that, so it is the case, right, that the IV here is calculating the effect for people who got access to ICU only because there was a bed available but wouldn't otherwise have had access to ICU had no density.
It's still a sort of intention to treat estimand in that they were more likely to get access to ICU because of the bed availability. So they didn't necessarily, so it's still an intention.
Supplier average.
Yeah, correct.
So they're getting treated only because there was a bed available but wouldn't otherwise be treated. And therefore is probably a lower bound estimate because these are the people that were on the border of being treated, right? Someone who really, really needed an ICU bed would have been treated anyway, therefore the treatment.
I think you're getting rid of people at either extreme. The people who were always going to be in there, they'd have kicked open the door of the ICU to get them in there, and the people who probably wouldn't. But the only thing to say is all of these people have been assessed for ICU admission, and so that other end of the spectrum, people who wouldn't ever have got into ICU, probably by design aren't in there. So yeah, I think you're not making inference about the people who they've absolutely kicked down the door of the ICU to get them in. Yeah. So that perhaps very, very severe end of the spectrum, or very inclined to benefit end of the spectrum, is not in there. So yeah, I get you. It perhaps is a lower bound, or yeah.
Thank you very much. Well, I've got two reactions. One is how incredibly useful these techniques are. I'm sure I was thinking they probably apply to almost all the evaluations that we carry out. So we will be using them. And related to that as well, that I'm sure it will be much less than 10 years before we invite you to come and explain so on. So thank you very much.